Okay, we are live on Facebook and YouTube.
Can I talk?
Yes.
Okay. So, good morning, everyone. First of all, I want to apologize for my absence on Thursday. I had an emergency surgery that did not allow me to arrive in time for the presentation. I want to say thanks to the organizing committee and what a pleasure it is to take part in this meeting, this cybernetic meeting. Yeah, because we are still in this pandemic situation that we stay very far for the other. Now, I would like to talk about the acute epidural hematoma in children. In many cases, worrisome neurosurgical emergence. I have no potential conflict of interest to report. And here you can see our hospital in Recife, Hospital da Restoration Hospital in English. Yeah, we have 180 beds in the neurosurgical department. 30 of them are pediatric beds. We have an emergency unit in pediatric trauma center. In the pediatric emergency, we have about 3,300 pediatric neurotrauma per year. We are 3 in the pediatric neurosurgery team. We have a resident program, and our hospital is an international training center for World Federation of Neurosurgical Society. So, the incidence of epidural hematomas in head injury vary from less 1 to 35%. 60% of them occur in patients under 20 years old. Less than 1 to 2.5% in small children, and 1.5 to 5% in older children. The general incidence of epidural hematomas is unknown because many cases are asymptomatic. The data show only the hospital cases, that's our hospital cases. Fortunately, the epidural hematomas represent a small number of head insurance children admitted to a neurosurgical service. In our series of 33,869 head trauma cases in children, only 1.4% had surgical indication due to epidural hematoma. In our cases, the most common traumatic mechanisms were falls, traffic accidents, bicycle accidents, and child mishandling. The clinical features of epidural hematomas differ from that observed in adults. Firstly, the classic triad, loss of consciousness, recovery, and again, the progressive consciousness deterioration are very hard in children. Especially in infants and young children, we observe a subacute evolution. Low hematocrit, pallidness, bradycardia, respiratory distress, drowsiness, irritability, Buget-Fontanelle, seizures, and sometimes neurological deficits. The most common symptoms listed on admission are vomiting, headache, and short unconsciousness, the last one immediately after the trauma. Previously, in the pre-tomographic period, a patient with a history of traumatic brain injury with some neurological signs and radiographic study showing an extensive fracture trace was considered a suspect of epidural hematoma. As you can see in this radiographic image, the presence of extensive cranial fractures crossing the suture could be suggestive of the presence and location of epidural hematoma. Today, the computed tomography is the most used tool in diagnosing epidural hematomas and increasing the diagnosis of minimally symptomatic patients. However, this can be a disadvantage since once diagnosed, they tend to be mandatorily operated on. The ultrasonography could be used in infants, but is very limited in the diagnosis of peripheral lesions. NMR is not indicating emergency case because of the time needed for the exam and the high cost involved. And what about the treatment? The classic approach is the craniotomy and evacuation of the hematoma. It's a routine procedure in trauma unit. Here you can see one of our operative cases. A child victim of being run over, persistent with drowsiness and left hemiparesis. Preoperative tomography showing a right parietal epidural hematoma. The postoperative tomography was very interesting, without, of course, the epidural injury, but with a post-decompression intraparenchymal frontal hematoma. The puncture is indicated only for children in case of a venous epidural hematoma. This is very hard situation, but that this can happen, for example, in sporadic case associated, infants in sporadic case associated with birth trauma. Despite many controversy, we have a third option, the conservative approach. And to illustrate the conservative approach, we have this case report, a boy, 10 years old, bicycle accident, without loss of consciousness or vomiting, arriving in our emergency 7 days after trauma. Glasgow Coma Scale 15, mild headache with good oral analgesic response, no neurological signs. You see here the CT with right side frontal epidural hematoma. What shall we do in this case? At the beginning of 2007, we observed some patients from the countryside who arrived in the emergency department many days after head trauma, sometimes 2-3 weeks later, with no complaints or neurological deficit, but an epidural hematoma in CT pictures. We asked ourselves what we shall do. In the past, most of these patients we brought in the OP round. But after this experience, we decided to observe more of this case and studied the conservative approach of epidural hematomas. Now we can introduce our experience of 153 cases conservative treated in the Hospital da Restauração. Actually, there would be 151 because of the worsening of two cases. Although unchanged CT picture, the craniotomy had been necessary. The patients arrived asymptomatic or mild symptomatic without neurological deficit, and the initial CT scan indicated epidural hematoma with no other intracranial lesion like contusion, subdural, or intracerebral hematoma. In our series, the male group represented 72%. The age ranged from 8 months to 13 years old. And you can see in this graph the age distribution. About local epidural hematoma distribution, 43% were frontal locate, 23% frontal parietal, 13% temporal, 16% temporal parietal, and 5% locate in posterior fossa. The epidural hematoma volume range from 5 cubic centimeter to 80 cubic centimeter, as you can see here in this graph. So there were several of these guidelines to indicate the conservative treatment of epidural hematoma. Some authors have tried to propose protocols based on the observed volume of hematoma on CT scan. As we see in this article published in 1994 concerning epidural hematoma in the posterior fossa. Other authors, based on clinical improvement, close supervision, considering the patient age, volume, and location of the hematoma, dared to establish criteria to indicate conservative treatment. Many authors advocate repeat CT scan to control the evolution of the hematoma, which also means a large radiation exposure. The international literature and our largest series suggests that although many epidural hematoma will need surgical treatment, conservative management may be considered. And here you can see all the publication on the conservative treatment of epidural hematomas and some more publication. Small series, not so large like our series that we presented now. So, then now I show you some of our case, like this case number 1. You have here the CT picture, the first day. After 15 days and 3 months later, we can't see hematomas anymore. Here, the second case, epidural hematoma with a little air in it. This is a fracture. 3 days later, and here, 4 months later. And we have here another case. This is an admission day, second day, 1 month later, And here, another case number 4, first day and the second day. In many of our first cases, when also due to insecurity, we controlled the evolution with repeat CT scans. We observed an increase in volume with a decrease in density. Still, in most cases, the patient remaining oligosymptomatic. So it's not a big problem if we observe a very small difference between the first and the second CT. That means the CT in admission and CT 1, 2, 3, or 4 days later. And here we have another case, the case number 5, a girl, with a fracture and big epidural hematoma in the admission day. And here you see 5 days later. And she gonna very good. 3 cases more, the case number 6, you see here, the first day, 6 days later, 4 months later. And here, in admission day, 5 days after trauma. Yeah, you can see here in this picture, light 6 cranial pair paresis without anisocoria. This is the 10 days after trauma and 45 days after trauma. Case number 8, in the second day after trauma, 5 days and 20 days after trauma. Is another case number 9, 15 days after trauma. This patient came to our emergency very late. 16 days. And in this case, we had the opportunity to do the NMR 7 days after trauma. As I said before, in the first 15 cases of this series, we were very insecure, especially about big hematomas, and we took many pictures. Now we do not repeat the CT in patients with good follow-up. So it's another case in the admission, and 4 days later, a small hematoma. Case number 11, first day, 3 days later. And here, this scale, this is the CT picture as she came to our emergency department. And we have another case. This is a epidural hematoma, fracture, and epidural hematoma together with subgaleal hematoma. This case is number 14, a small epidural hematoma. All this case that we showed only one picture, where a case that we took only one CT. The patient had really a very good evolution, that CT control was not necessary. We have been modifying our protocol over the years and with the experience acquired in the pediatric emergency. In the beginning, we needed a lot of controlled CT scan. Still, today, taking into account the child's clinical evolution, we repeated that we repeat the CT scan only in the phase of clinical worsening. So, to conclusion, conservative management can be considered based on Glasgow Coma Scale 15. The patient comes to emergency in Glasgow Coma Scale 15, normal neurological findings, asymptomatic or oligosymptomatic, admission CT without midline shift bigger than or larger than 0.5 centimeter, volume of the epidural hematoma less than 60 cubic centimeter, but depending on the clinical feature, yeah, you showed that we had case with more than 80 cubic centimeter. Close supervision for 48 to 72 hours. It's very important that the patient showed clinical improvement. And currently, we do not perform controlled CT scan if the patient is clinically stable within 48 to 72 hours of observation. Thank you very much. And if you have any question, I try to answer it. Thank you.
Muchas gracias, doctor Cunha, por la excelente presentación. Yo tengo una pregunta. ¿Qué por ciento de los pacientes que ustedes inicialmente comenzaron a manejar de forma conservadora tuvieron que llevar a cirugía? ¿Qué por ciento de estos pacientes que en las primeras horas estuvieron estables tuvieron que hacerle cirugía?
In this series, from 153 patients, only 2 patients.
Gracias. ¿Y qué aspecto ustedes le dan más valor en el seguimiento de estos pacientes? ¿Las imágenes o la evolución clínica para decidir qué conducta realizar?
Nosotros hemos valorizado más y más los aspectos clínicos, porque tenemos que llevar en consideración que en especial en niños muy pequeños, ellos soportan muy bien la expansión de un hematoma y por eso que seguimos de una forma clínica. Claro que valorizamos también los hallazgos de la tomografía computadorizada, por ejemplo, sobre la localización del hematoma y el volumen del hematoma y si hay un desvío de la línea media. Estas son cosas muy importantes, pero la clínica, hemos valorizado mucho más la clínica de los pacientes. ¿Ya?
Muchas gracias. No sé si hay anybody has some question to the professor.
Son las únicas preguntas por el momento.
Bueno, muchas gracias, profesor Héctor Cunha, por su excelente presentación. Realmente es un tema muy interesante para los que utilizamos neurocirugía pediátrica.
Yo agradezco también la oportunidad y una vez más ahora en español. Pido disculpas por lo que se pasó en jueves, pero desafortunadamente como estamos en nuestra ciudad, a veces las cosas pueden acontecer imprevistos y tenemos que estar ahí en las situaciones de emergencia. Inclusive yo estaba muy preocupado porque hoy por la mañana temprano hubo una explosión de una estación de electricidad y por unas 3 horas nos quedamos sin electricidad y estaba preocupado si teníamos tiempo para llegar hasta esta conferencia, mas muy bien, lo repararon en poco tiempo y tanto que aquí estoy. Gracias una vez más. Thank you very much all, and I hope to see you personally very soon. Ciao, bye-bye.
Bye-bye.
Sir, thank you for your time and for your incredible presentation.
Thank you.